I want to start with a number that I think is one of the most underreported health statistics in modern medicine. Approximately 1 in 3 adults worldwide now has non-alcoholic fatty liver disease. Not 1 in 3 unhealthy adults, not 1 in 3 obese adults, 1 in 3 adults. In some countries and some demographics, the prevalence is approaching 1 in 2. This is a condition that has gone from being considered rare 30 years ago to being the most common liver disease on the planet, and it has done so almost entirely without public awareness. The reason it has happened so quietly is the same reason most of the conditions in this series are so dangerous. The liver has no pain receptors. You cannot feel your liver struggling. You cannot feel fat accumulating in your hepatocytes. You cannot feel inflammation developing within liver tissue or early fibrosis forming as a response to that inflammation. The liver can be significantly damaged, functionally impaired, structurally scarred, and produce nothing more than a vague fatigue that most people attribute to being busy, being older, or not sleeping well enough. I covered the warning signs of liver disease in video 1 of this series. If you have not watched that video, I would encourage you to do so. It covers the 9 subtle signs that your liver is in trouble, and many of them are directly relevant to fatty liver disease. In this video, I want to go deeper into the mechanism of how fatty liver develops and progresses, the specific dietary and metabolic drivers that cause it, the populations at risk that most people would not expect, and the evidence-based interventions that can reverse it. Because the most important thing about fatty liver disease, and the thing that makes it fundamentally different from many of the other conditions in this series, is that in its early and intermediate stages, it is completely and measurably reversible. By the end of this video, you will understand exactly how fat accumulates in the liver and why it matters. The progression from simple steatosis to cirrhosis and liver cancer, who is most at risk, including the lean and normal weight individuals who are consistently missed, the dietary and lifestyle factors driving the epidemic, the tests that detect it before significant damage occurs, and the 8 evidence-based actions proven to reverse it. This is the most actionable video in this series. Let us get into it. Non-alcoholic fatty liver disease, NAFLD, is defined as the accumulation of fat in more than 5% of liver cells in people who drink little or no alcohol. The name is somewhat misleading because the condition has nothing to do with alcohol consumption. It is driven by metabolic factors. More recently, the medical community has moved toward calling it metabolic dysfunction-associated steatotic liver disease, MASLD, to better reflect its true nature as a metabolic condition. For clarity in this video, I will use NAFLD, as this remains the most widely recognized term. The first stage is simple steatosis, fat accumulation in liver cells without significant inflammation or damage. At this stage, the liver is enlarged and fatty, but liver function is largely preserved. Many people remain at this stage indefinitely without progressing. The liver has remarkable regenerative capacity, and simple steatosis is fully reversible. This is the stage at which intervention is most effective and the window of opportunity is widest. The challenge is that simple steatosis produces virtually no symptoms. Most people who have it have no idea. In approximately 20 to 30% of people with NAFLD, the condition progresses to non-alcoholic steatohepatitis, NASH. At this stage, fat accumulation is accompanied by active inflammation and liver cell damage. The liver begins to show histological injury. Liver enzymes, particularly ALT and AST, may be elevated on blood tests, although many people with NASH have normal liver enzyme levels, which is one of the reasons the condition is so consistently missed. NASH carries a significantly higher risk of progression to fibrosis and cirrhosis than simple steatosis. As NASH progresses, inflammatory damage triggers the formation of fibrous scar tissue, fibrosis, in the liver. Fibrosis is graded on a scale of F0 to F4. F4 is cirrhosis, the point at which the liver architecture is so extensively replaced by scar tissue that its function is critically impaired. Cirrhosis caused by NAFLD and NASH has become one of the leading indications for liver transplantation in many countries, overtaking alcohol-related liver disease in some regions. And the trajectory from NAFLD to cirrhosis, which once took decades, is accelerating in a population where the metabolic drivers are becoming more prevalent at a younger age. People with advanced NAFLD and NASH also have a significantly elevated risk of hepatocellular carcinoma, primary liver cancer, even in the absence of cirrhosis. This is one of the clinically distinctive features of NAFLD compared with other liver diseases. The risk of liver cancer can develop at earlier fibrosis stages than in hepatitis C or alcohol-related disease. Liver cancer is the sixth most common cancer globally and one of the fastest-growing causes of cancer mortality in many countries. The majority of cases now occur in the context of metabolic liver disease. The populations most commonly associated with NAFLD are those with obesity, type 2 diabetes, insulin resistance, and metabolic syndrome. The combination of abdominal obesity, high blood pressure, elevated triglycerides, low HDL, and impaired fasting glucose. These associations are real and well established. Approximately 70 to 80% of people with obesity have NAFLD. Approximately 70% of people with type 2 diabetes have it. Approximately 90% of people with morbid obesity undergoing bariatric surgery are found to have it on liver biopsy. The metabolic connection is direct. Visceral fat and insulin resistance drive hepatic fat accumulation through multiple mechanisms. But here's the clinical reality that most NAFLD discussion misses entirely. A significant proportion of people with fatty liver disease are normal weight or only mildly overweight. In population studies, approximately 10 to 15% of normal weight adults, those with a BMI below 25, have NAFLD. In some Asian populations, this proportion is considerably higher. These individuals, called lean NAFLD, are consistently missed because no one thinks to screen them. Their BMI looks reassuring. Their waist circumference may be within normal range, but their liver is accumulating fat, and in some studies, lean NAFLD carries a worse prognosis than obese NAFLD, possibly because the diagnosis is delayed longer. Lean NAFLD appears to be driven primarily by dietary patterns, particularly high fructose consumption, ultra-processed food, and low dietary fiber, rather than overall caloric excess. It is also associated with genetic variants, particularly the PNPLA3 and TM6SF2 gene variants, which affect hepatic fat metabolism. South Asian populations have a particularly high genetic susceptibility to hepatic fat accumulation at lower BMI levels, which is one of the reasons that NAFLD prevalence is so high in India and in South Asian diaspora communities globally. If you are South Asian, or if you have a strong family history of liver or metabolic disease, you are in a high-risk group for NAFLD regardless of your weight. The primary dietary driver of hepatic fat accumulation is fructose, specifically the fructose in added sugars and high fructose corn syrup in ultra-processed foods and sugary drinks. Unlike glucose, which can be metabolized by virtually every cell in the body, fructose is processed almost exclusively in the liver. When consumed in excess, particularly in liquid form, where it is absorbed rapidly without the moderating effect of fiber, fructose overwhelms the liver's processing capacity and is converted directly to fat through a process called de novo lipogenesis. A single high fructose meal can produce measurable hepatic fat accumulation. Repeated daily consumption of sugary drinks, fruit juice, and ultra-processed snacks containing added sugars creates a sustained state of hepatic fat deposition that accumulates over years. The second major driver is insulin resistance, the same metabolic dysfunction we discussed in the diabetes video. When cells become resistant to insulin, the liver receives conflicting signals. It continues producing glucose despite elevated blood insulin, and it increases triglyceride production. Elevated triglycerides in the portal circulation, the blood supply from the gut to the liver, promote hepatic fat storage. Insulin resistance and NAFLD form a bidirectional relationship. Insulin resistance promotes hepatic fat accumulation, and hepatic fat accumulation worsens insulin resistance. Breaking this cycle is the central therapeutic target. Beyond fructose specifically, the broader pattern of ultra-processed food consumption drives NAFLD through multiple mechanisms. High caloric density promoting overall fat accumulation, disruption of the gut microbiome, which plays a key role in regulating hepatic fat metabolism, reduction of dietary fiber, which modifies bile acid circulation affecting liver fat, and the presence of emulsifiers and preservatives, which have been shown in animal models to promote intestinal permeability, leaky gut, increasing the load of bacterial products reaching the liver through the portal circulation and triggering hepatic inflammation. A note on alcohol. The NAFLD diagnosis specifically excludes significant alcohol use, but moderate alcohol consumption, above 14 units per week, does contribute to hepatic fat accumulation and can accelerate the progression of NAFLD that is already driven by metabolic factors. People with NAFLD are advised to reduce alcohol to below 7 units per week and ideally eliminate it entirely during the period of active liver fat reduction. The liver cannot efficiently metabolize both dietary fat and alcohol simultaneously, and any alcohol consumption increases the inflammatory burden on an already stressed liver. I covered 9 liver warning signs in video 1. Here I want to focus on the specific signs most commonly associated with NAFLD and NASH, the signs that tend to appear as the condition progresses from simple steatosis towards significant fibrosis. The most common and most consistently reported symptom of NAFLD across all stages is unexplained persistent fatigue, a tiredness that is qualitatively different from ordinary tiredness and that does not resolve with sleep. The mechanism is multifactorial. Impaired liver function affects the processing of ammonia and other nitrogenous waste products, which have direct effects on brain energy metabolism. Reduced glycogen storage capacity in a fatty liver means that blood glucose regulation between meals is less efficient, contributing to energy fluctuations. And the chronic low-grade inflammation associated with NASH drives the same inflammatory fatigue that characterizes other chronic inflammatory conditions. Most people attribute this fatigue to their busy lifestyle or poor sleep. In the context of other signs on this list, it is worth investigating. The liver sits under the right rib cage. As it enlarges, hepatomegaly, due to fat accumulation, the liver capsule stretches and can produce a dull ache, pressure, or fullness in the upper right quadrant of the abdomen. This is often described as a vague heaviness rather than a sharp pain. It may be intermittent and is frequently attributed to indigestion, muscle strain, or gas. In an otherwise asymptomatic person, this sign alone is not diagnostic, but in someone with known metabolic risk factors, upper right abdominal discomfort warrants an ultrasound assessment of the liver. ALT, alanine aminotransferase, and AST, aspartate aminotransferase, are liver enzymes that leak into the bloodstream when liver cells are damaged. Mildly elevated ALT and AST, typically 1 to 3 times the upper limit of normal, are one of the most common incidental findings in routine blood tests and are one of the primary ways NAFLD and NASH are first detected. Many people are told their liver enzymes are slightly raised and that they should reduce alcohol, even when they drink very little, without any investigation of the metabolic causes. If your liver enzymes are elevated and you have any of the metabolic risk factors for NAFLD, please ask for a specific NAFLD assessment, including a liver ultrasound and a FIB-4 score. In more advanced NAFLD and early hepatic dysfunction, the liver's reduced capacity to clear nitrogenous waste products, particularly ammonia, from the blood produces subtle cognitive effects. People describe difficulty concentrating, a sense of mental sluggishness, word-finding problems, and reduced mental stamina. This is a mild form of hepatic encephalopathy. The more severe form, which occurs in established cirrhosis, involves confusion, disorientation, and altered consciousness. The early cognitive effects are subtle enough to be attributed to stress, aging, or poor sleep by virtually everyone who experiences them. A less obvious but clinically important sign is the pattern of worsening metabolic health despite what appears to be reasonable lifestyle efforts. Rising triglycerides, rising fasting glucose, increasing waist circumference despite stable total weight, and progressively elevated liver enzymes. This constellation of metabolic deterioration, particularly when it occurs in someone who does not consider themselves particularly unhealthy, should prompt a targeted NAFLD assessment. The liver is both a driver and a consequence of metabolic syndrome, and when it is significantly fatty, its dysfunction amplifies the metabolic dysregulation in a self-reinforcing cycle that does not respond well to modest interventions. A standard liver function test, LFTs, includes ALT, AST, alkaline phosphatase, gamma-GT, bilirubin, albumin, and clotting factors. Elevated ALT and AST are the most common abnormalities in NAFLD, but as I noted earlier, a significant proportion of people with NAFLD and even NASH have entirely normal liver enzymes. Normal LFTs do not exclude fatty liver disease. Liver ultrasound is the first-line imaging investigation for NAFLD. It is widely available, inexpensive, non-invasive, and can detect moderate to severe hepatic steatosis with reasonable sensitivity and specificity. It cannot reliably detect mild steatosis and cannot assess fibrosis stage. But for most people, a liver ultrasound is the appropriate starting point for investigation. The FIB-4 score, fibrosis 4, is calculated from age, ALT, AST, and platelet count. It is a validated, inexpensive, and widely available non-invasive marker of liver fibrosis. A FIB-4 below 1.3 has a high negative predictive value for significant fibrosis. It essentially rules out advanced liver disease. A FIB-4 above 2.67 warrants further investigation with FibroScan or liver biopsy. The FIB-4 can be calculated from any standard blood test result and is the most clinically useful risk stratification tool available for NAFLD in primary care. FibroScan, transient elastography, is a non-invasive ultrasound-based device that measures liver stiffness, a proxy for fibrosis, and hepatic fat content simultaneously. It is painless, takes 10 minutes, and provides a highly accurate assessment of both fibrosis stage and steatosis grade. It is increasingly available in secondary care liver clinics and some primary care settings. For people with elevated FIB-4 scores, a FibroScan is the next appropriate investigation before considering liver biopsy. These 8 actions are not generic lifestyle advice. Each of them has specific evidence from liver biopsy studies, imaging studies, or randomized controlled trials demonstrating a measurable reduction in hepatic fat content, liver enzyme levels, or fibrosis stage. This is what reversal looks like clinically. Weight loss is the most consistently effective intervention for NAFLD across all stages. The landmark evidence comes from multiple biopsy-proven studies. Losing 7% of body weight reduces hepatic steatosis in the majority of patients. Losing 10% of body weight reduces not just steatosis, but NASH activity and fibrosis in a significant proportion of patients, a finding that is remarkable because fibrosis was previously considered largely irreversible. For a person weighing 90 kilograms, a 7% loss is 6.3 kilograms. This is achievable. The distribution of weight loss matters. Visceral fat loss produces greater hepatic benefit than equivalent subcutaneous fat loss, which is why waist circumference reduction is a better target metric than scale weight. This is the highest yield single dietary change for hepatic fat reduction. Sugary drinks, regular cola, fruit juice, energy drinks, sports drinks, sweetened coffee, are the primary source of liquid fructose in most people's diets and the most directly hepatotoxic component of the Western dietary pattern. Eliminating sugary drinks produces measurable reductions in hepatic fat within weeks in imaging studies. Fruit juice, including freshly squeezed, contains as much fructose as regular cola and should be treated identically in the context of NAFLD. Eat fruit whole, where the fiber moderates fructose absorption. Do not drink it. Ultra-processed food drives NAFLD through multiple mechanisms beyond fructose: caloric density, gut microbiome disruption, emulsifier effects on intestinal permeability, and displacement of fiber-rich whole foods that support hepatic fat metabolism. A practical target is reducing ultra-processed food to fewer than 20% of total calorie intake. The most hepatoprotective dietary pattern identified in clinical studies is the Mediterranean diet, emphasizing olive oil, vegetables, legumes, whole grains, oily fish, and nuts, with minimal ultra-processed food. In people with NAFLD, Mediterranean dietary adherence is associated with significant reductions in liver fat independent of weight change. Exercise reduces hepatic fat through 2 independent mechanisms. It increases hepatic fat oxidation directly. The liver burns more of its stored fat during and after exercise. And it improves insulin sensitivity, reducing the ongoing hepatic fat deposition driven by insulin resistance. Aerobic exercise and resistance training both reduce hepatic fat in imaging studies, with resistance training showing particular efficacy for reducing liver stiffness and improving metabolic markers. The minimum effective dose is 150 minutes of moderate aerobic exercise per week, but studies suggest that 250 to 300 minutes provides substantially greater hepatic benefit. Importantly, exercise reduces hepatic fat independently of weight loss, meaning that even if a person does not lose significant weight, exercise still directly reduces the fat content of the liver. In the context of NAFLD, alcohol is an additive hepatic stressor. The liver cannot efficiently metabolize both dietary fat and alcohol, and any alcohol consumption increases oxidative stress and inflammatory burden in an already metabolically stressed liver. Current guidance for people with confirmed NAFLD is to reduce alcohol to below 7 units per week, and ideally to eliminate it entirely during active liver fat reduction. This is not the same advice that applies to the general population. It is specific to the context of a liver that is already under metabolic strain. Obstructive sleep apnea is independently associated with NAFLD severity and fibrosis progression through the mechanism of intermittent hypoxia, repeated overnight oxygen drops that produce hepatic oxidative stress and inflammation. Multiple studies have demonstrated that treating OSA with CPAP therapy reduces liver enzyme levels and hepatic inflammation in people with NAFLD. Poor sleep quality more broadly, fewer than 7 hours, fragmented sleep, circadian misalignment, impairs insulin sensitivity and drives the metabolic dysfunction that feeds hepatic fat accumulation. Sleep is not a passive background variable in NAFLD management. It is an active therapeutic target. GLP-1 receptor agonists, particularly semaglutide, which we discussed in the diabetes video, have demonstrated striking efficacy for NAFLD and NASH in clinical trials. The NASH trials of semaglutide showed resolution of NASH in approximately 59% of patients versus 17% on placebo, with significant reductions in liver fat and enzyme levels. Semaglutide is now approved for NASH in several regulatory jurisdictions, making it the first pharmacological therapy specifically licensed for this indication. For people who are eligible, those with obesity, type 2 diabetes, or high cardiovascular risk alongside confirmed NAFLD, this is a treatment worth discussing explicitly with your doctor, not just for its glucose lowering or weight loss effects, but for its direct hepatic benefit. The most important action for anyone watching this video who has any of the risk factors I have described, obesity, diabetes, insulin resistance, metabolic syndrome, elevated liver enzymes, South Asian ethnicity, or a family history of liver disease, is to get a FIB-4 score and liver ultrasound. The FIB-4 requires nothing more than a standard blood test that includes ALT, AST, and platelets, results most people already have on record. If you do not have these results, ask for them at your next appointment and ask your doctor to calculate a FIB-4. Early detection changes outcomes dramatically. A FIB-4 below 1.3 in a person with risk factors is reassuring. Above 1.3, further investigation is warranted. You cannot act on information you do not have. Fatty liver disease has gone from a rare clinical curiosity to the most common liver disease on the planet in the space of a generation. That trajectory is driven by identifiable, modifiable factors, the same dietary and metabolic drivers that we have discussed across this entire series. And the reversal evidence is genuinely remarkable. Weight loss, dietary change, and exercise can reverse not just the fat accumulation, but the inflammation and fibrosis of NASH in a way that no other common liver disease responds to non-pharmacological intervention. You have more power over this condition than over almost any other on this list. 8 videos in: liver, blood pressure, kidneys, diabetes, heart disease, stroke, cholesterol, and now fatty liver disease again in its full clinical depth. The same visceral fat, the same insulin resistance, the same ultra-processed diet, the same sedentary lifestyle appear as a cause or aggravating factor in every single one of these conditions. That is not a coincidence. That is the biology of metabolic syndrome. Address the root, the metabolic environment, and you protect every organ simultaneously. If this video has prompted you to take your liver health more seriously, or if it has made you think of someone whose liver health you are concerned about, please share it. The information in this video is not widely known, and it reaches people who need it only if you pass it on. Subscribe so you do not miss video 9, where I will be covering sleep apnea, the condition affecting 1 billion people worldwide, causing hypertension, heart disease, diabetes, and fatty liver simultaneously, and that most people have never had properly investigated. I will see you there.